again what I have said. Cross-sectional study representing the time right now, and it is called survey study, and it answers the question, what is happening right now? Why case control study is representing time in the past, and it is called retrospective study, and it answers the question, what happened? Why the cohort study representing the time in the future, and it is called prospective study, and it answers the question, what will happen? Okay? So this is the observational studies. I summarize it in 4 types of observational studies: case series, case survey, case control, and the cohort. Case series means that I study hypothesis, I put hypothesis over a small number of patients. Then I want to test this hypothesis. I can test it through the other 3 types of observational study. Case control study is a retrospective study representing the time in the past, from today to yesterday. Survey study is representing the time right now. Cohort study is representing time in the future. Am I clear? Any questions? Because if you lost any information, it will be difficult to follow. Don't be scared to ask me and stop me if you have any question. It's okay now?
Doctor, this series is what? It's only to have hypothesis and small number of patients. Because according to the time.
This is not according to the time. This series has a limited period of time. We do it in a short period of time. To put hypothesis. And if you feel that this hypothesis is sound, you test it by the other 3 types: the case control, the survey, or the cohort. It is not necessary to be sequential. Every type of the studies has its own aim and its own design. Okay? ماشي كده كويس؟ Okay? Then the other part of studies is the interventional studies or experimental studies. The term experimental does not mean experimental animals. Experimental, that you are doing an experiment. This experiment could be done on animals or on humans. And as I said, interventional or experimental and studies and intervention is done, and the effect of intervention is observed. These interventional studies could be controlled or non-controlled. And according to the time lag between the study and the control, interventional studies could be parallel or concurrent if the study and the control groups are carried out at the same time. And this is the most common. And this could be randomized or non-randomized. If the control is sequential or after the study, then the study could be a study with self-control or crossover study. But if the control is done after the study, before the study, this is the study will be a study with historical control. Now we are entitled to discuss this item only, which is randomized clinical trials. Because I had a very big talk about the kinds of the studies, and this should be given to you before this lecture. But I'm trying to summarize it in few words. A confusing item is the difference between cohort means prospective study, and randomized clinical trials. What is the difference between cohort study and randomized clinical trial. This is general information that each study has two important items. The first item is the start point, which is the item under investigation, and the next item is the end point of the study, which is the outcome. So I give you an example to understand this, what is the item under investigation, which is the start point, and what is the outcome, which is the end point of the study. All of us know that a prolonged use of birth control pills may increase the risk of development of breast cancer. So we will use this example to explain the different types of these studies. So, prolonged use of birth control pill may cause breast cancer. So if I ask you what is the item under investigation here, use of birth control pills, and what is the outcome will be breast cancer. Okay. So I make a diagram to explain the cohort study. Here is the direction of time. Here we are in 2013, and we are passing forward in time for 5 years until 2018. At 2013 right now, I choose a group of middle-aged women. Then I classify them into two groups. Group already taking birth control pill, and another group already not taking birth control pill. So these two groups, you want to do intervention that you do not decide to give or not to give birth control pills, but they are already, the group already taking birth control pills, and the other group already not taking birth control pills. So you don't have any influence about the two groups whether to take or not to take birth control pills. Okay? Then you, this is here in 2015, and then after 5 years, 2013, after 5 years of follow-up, among the group which are already using birth control pill, after 5 years, you do investigation to see presence of breast cancer or presence of no breast cancer. And among those already not taking birth control pills, after 5 years of follow-up, at 2018, you will investigate who are having breast cancer and who are not having breast cancer. So this is the direction of the inquiry, here the direction of time, and the question is, how will the use of birth control pill affect the prevalence of breast cancer in middle-aged women? Is it clear? This is in a simple language, in a clinical language. I want to convert this into statistical language, because if I speak to you in the statistics, you will not understand it. So if I convert this example into statistical language, I am saying, here is the direction of time. Here we are in 2013. In 2013, I choose a cohort selected for the study. Then I classify them into two groups: subjects already exposed to the risk factor, and subjects, control subjects, which are already not exposed to the risk factor. And among those already exposed to the risk factor, after 5 years of follow-up, I investigate who will develop the outcome and who will not develop the outcome. And among the control group, which are not exposed to the risk factor, after the 5 years of follow-up, I will do investigation to see who will develop the outcome and who will not develop the outcome. Am I clear? Clear? So coming to the randomized clinical trial, on the other hand, here the onset of the study in 2015, and here in 2015. Following the same example, at 2013, I chose a group of middle-aged women. Then I do intervention. What is intervention is, I do randomization, whether to give or not to give birth control pills. So this is now interventional study, because I did intervention and myself I decided to give or not to give birth control pills. But in the cohort studies, the group of women were either already taking birth control pills or not taking birth control pills by their own. You did not interfere to give or not to give them the birth control pills. Then, after 5 years of follow-up, who are given birth control pill, I see who will develop breast cancer and who will not develop breast cancer. And on the other hand, who are not given birth control pill, who will develop breast cancer and who will not develop breast cancer. And if I convert this to the statistical language, I say at the onset of the study, I choose subjects meeting entry criteria. Then I do intervention through randomization. I classify them into subjects, experimental subjects exposed to the risk factor, and control subjects not exposed to the risk factor. And after 5 years of follow-up among experimental subjects, I will see, I do investigation to see who will develop the outcome and who will not develop the outcome. And among controls which are not exposed to the risk factor, after 5 years of follow-up, I do investigation to see who will develop the outcome and who will not develop the outcome. So in the cohort study, there is no intervention, as the item under the study is already existing and observation is gone forward in time, while in randomized clinical trial, there is intervention through deciding to give or not to give the item under the study. Then observation is done forward in time, and in randomized clinical trials, decision to give or not to give the item under the study is taken by randomization. Clear? Yes. Clear? Any questions up to now? Then, what are the types of controls in randomized clinical trials? These are the types of controls. Could be gold standard, reference standard, or standard of care. Could be placebo, or could be a sham operation. For the gold standard, it is defined as something that passed the test of time. For example, it could be a treatment that, for example, non-steroidal anti-inflammatory drugs is the gold standard for treatment of renal colic, or BTDL or morphine is the gold standard treatment of renal colic. If I want to test another medication to treat renal colic, I have to refer the results to the gold standard, which is the non-steroidal anti-inflammatory drug. Also, for surgical procedures, for example, appendectomy is the gold standard for treatment of appendicitis. If I want, for surgical, by surgery, for example, if I want, for example, to see laparoscopic cholecystectomy, appendectomy, I have to test it against the open standard technique. And this gold standard could be diagnostic modality, for example, radiological, for example, renal trauma, for example, CT angiography, CT with contrast is the gold standard to investigate or to do investigation for a patient with renal trauma. If I want to do something else, I have to refer to the gold standard. Endoscopic, for example, cystoscopy is gold standard for visualization of the tumor in the bladder. If I want to test, for example, something else, I want to refer it to the cystoscopy. And the histopathology is the gold standard for treatment, for diagnosis of most of the oncological cases. If I want to study something else, I have to refer to the gold standard. The next type is the placebo. It is used in pharmaceutical studies. The drug under investigation is tested against the phantom having the same shape, color, weight, and taste, but having no effective material. And this placebo is important to nullify the psychological effect of receiving treatment. If I want, for example, there is a new medication for treatment of myocardial hyperplasia. If I want to do a proper randomized clinical trial, I have to test it against the placebo. So I give a group of patients with randomization the proper medicine, and the other group I give them placebo. This placebo having the tablet have the same weight, the same color, the same shape. Everything is identical to the original drug, but it contains starch or sugar or vitamin B, etc. Because if you convince a patient that he is having a very strong medication, there will be a psychological effect that he will be improved psychologically, and this psychological effect will be reflected to the improvement of symptoms. So this placebo is used in testing pharmacological studies. Then the sham operation is used in surgical studies. The animal is opened, the concerned organ is identified and dissected, then the wound is closed. Sham operation is important to nullify the effect of anesthesia, incision, and the closure of all wound areas. For example, if I'm saying that there is a certain medication that can protect the ureter, the obstructed ureter, can protect the harmful, can act against the harmful effect of obstruction of the ureter. So I open the animal, then I do closure of the ureter. Then I close the animal. This is one group. Another group, I do the same, but I give the protective, the presumed protective drug. If I design the experiment in such a way, it is wrong. Why wrong? Because someone, they assume that the anesthesia, the doing the incision or closure of the wound may have an effect on the results. So to nullify this, I have to add a third group. So I have a study group containing the surgery and the medication, a control group containing the surgery with no medication, and the sham group. What sham group? I open the animal, then I take the ureter and I make some movement of the ureter like this, then I close the animal again, and I give the animal something to recover the animal from the anesthesia. So this sham operation will nullify the effect of anesthesia, of opening the abdomen of the animal, and of closure of the abdomen of the animal. You understand? Okay? Is it clear? For example, I did a research, and I want to test a medicine that protects the kidney against obstruction. You know that if the ureter is obstructed, for example, this will be reflected on the function of the kidney. The longer the obstruction, the more harm effect on the kidney. So I want to discover a medication that can protect the kidney against the harmful effect of this obstruction of the ureter. So I do an experiment. I open, for example, rat or dog or rabbit. Then I close the ureter and I give the animal the medicine. This is the study group. Okay? To study this, I have a control group that I do the same, but I don't give the medicine. Okay? This, if I design the experiment like that, it is something important is missing. which is the sham group. What is sham group? Because someone may presume that the medications given in the anesthesia or the opening of the wound and the closure of it may have effect on the results. So to nullify these effects, I have to design a third group that I do anesthesia, I open the animal, then I go to the concerned organ, which is the ureter, and I make it like this. Don't interfere, just movement. Then I close the wound and I do recovery of the animal from anesthesia. This is the sham effect. This is because I did movement while making, doing obstruction of the ureter. So I mimic everything like the study group and like the control, but without the effect. What is the effect? Which is closure of the ureter and giving the medication. Okay? Am I clear? Then what are the methods of randomization? There are two common methods of randomization, the closed envelope and the computer-generated random table. What is the closed envelope? For example, I wanted to evaluate 100 patients with hepatitis C. Then I want to test a new medicine. The gold standard, I presume that the gold standard for treatment of this disease is drug A. Okay? Then I want to test another drug, which is drug B. So I want to classify the 100 patients into 50-50. What I do, I bring 50 papers and I write on each of them A. Then I close the paper and I put it in envelope and I put it in the box. Then I bring 50 other papers and I write B. Then I close and I put in envelope and I put it in the box. Then I shake the box. And when I go to do the operation, the experiment today, I shake the box. This number one, patient number one. I shake the box and I catch one envelope. It is A. So patient number one will receive drug A, and etc. When I finish the 100 patients, then you will find that 50 patients will take drug A and another 50 patients will take drug B. This is a very common method of randomization, which is the envelope technique. Another technique is the computer-generated random tables. There is a software in the computer. Just you feed the computer by the total number of patients, of the study group, patients or animals or anything. Then the number of groups, for example, in our example, it is 100, two groups, and the ratio between the two groups. This is ratio 1 to 1. One study versus one control. Okay? Then you click the button, then you will find that the computer will generate two tables. Table for drug A contains number 1, 7, 14, 20, etc. 50 numbers. And the table for drug B that contains other 50 numbers. Then when patient comes, you see this is patient number 10, for example. And I see what is the location of number 10 in the two tables. It is present in table B. So this patient will receive treatment B. Or if patient number 12 it is present in table A, this patient will receive medication A. Okay? Is it clear? This both are okay, no problem. The easiest, both are okay, no problem. But when you do the envelope, then make it mask it because don't make special color, special size, or and let somebody else, not you, not the investigator, to catch the envelope. Then masking is important. Randomized clinical trials are of three types. Open label means that everything is known. The nature of the study is known to the patient, and also it is known to the doctor. So it is open label and I'm not sure. Everything is known for everybody. If I read blind randomized clinical trial, blind means that it is blind to the patient, but it is known to the doctor. If I read double blind means that it is blind to both patient and doctor. I'll give examples. This is an example of open label study. A group of authors conducted a randomized clinical trial of 100 patients with glycocytic hyperplasia. Patients were randomized into two equal groups. Group A received gold standard treatment of glycocytic hyperplasia is alpha-1A blocker called tamsulosin. And the group B received another new alpha blocker, it is alpha-1B, it is called naftopidine. All patients know the type of treatment received, and the follow-up was carried out by the same doctors who already know the type of treatment received by the patient. So the patient knows the type of treatment, and the evaluating doctor also knows the type of treatment. So this is an open label study. This is a subject of bias. Why a subject of bias? Because every one of us, when you do an experiment, you are enthusiastic about the hypothesis in your mind. You internally like that the medicine you suggested, you hope that it works. You wish from inside, you want this medicine to work. So you will be biased. If you know this patient is taking your medicine, your hypothesis, your suggested hypothesis, you will be biased towards your own hypothesis. So open label randomized study is weaker than blind, and the most reliable is the double blind. Okay? And this is an example of blind study. A group of authors conducted a randomized clinical trial for 100 patients of nitrocytic hyperplasia. Patients were randomized into two equal groups. Group A, 50 patients received the alpha blocker tamsulosin, and Group B, 50 patients received the placebo. All patients did not know the type of treatment received. Okay? But patients were followed up by the same group of doctors conducting the study who know the type of treatment received by each patient. So this is a blind study. Why blind? Because the patient does not know the type of treatment. Why it is weaker than the double blind? Because the patient himself may be biased. If I know that I'm taking placebo, then I will imagine that it should be no difference. So there will be a bias from the patient side. Okay? And for double blind, this is an example. A group of authors conducted a randomized clinical trial of 100 patients with nitrocytic hyperplasia. Patients were randomized into two equal groups. Group A, 50 patients received alpha blocker tamsulosin, and Group B received placebo. All patients did not know the type of treatment received, and the patients of both groups were followed up by a doctor not sharing in the study and was not aware of the kind of treatment received by each patient. So this is the best evidence-based proof that the drug is effective. It is blind to the patient and blind to the doctor. This is the strongest type of studies.
Suppose there is an application, for example.
If you can stop the study at any time if it proves unethical. For example, if you are testing a new medicine and then you find that after 10 patients, 5 of them developed complications, so you cannot continue.
I think in this occasion, the principal investigator breaches the code. If the complication are lying within the control group or the placebo, we can continue to start. But if they found that after breaching, the complication is in the active arm, so the study should be terminated prematurely because of side effects.
Okay. And the very famous international studies are terminated before they propose the date because of this, because they found that a lot of complications are occurring, so they have to stop it. And as Professor Hussein said, you have to explore or to breach the mask and to see whether the complication is from the medicine. You have to stop it. And you can publish it also. You can publish it also to warn others not to use this medicine. Then, randomized clinical trial as part of drug approval. And for approval of drugs, the medicine should pass into 3 phases. The randomized clinical trial is a classic phase 3. We have phase 1, phase 2, phase 3. Phase 3 is randomized clinical study. What is phase 1? Phase 1 is to test the initial effect to administer the treatment to human being. It includes experimental animal studies to adjust the dosage regimen and to evaluate the potential toxicities. But it also includes the human volunteers, and it provides only a preliminary look at the potential efficacy of the therapy. Just to have the look, just to have an impression about this. Is it toxic? Is it harmful? Is it tolerable? Is it effective, etc. And it includes animal studies and a small number of volunteers of humans. If the medicine passed the phase 1, then you go to phase 2. Phase 2, it is a small scale controlled or uncontrolled trial, and the aim is to establish whether a full scale randomized clinical trial should be conducted. So if you do phase 2, that includes a small number of patients, controlled or not controlled, and you find that it is effective, phase 2 is successful, then you upgrade to phase 3 trial. And this is the phase 3 is the classic randomized food and drug administration. When any medication should not be allowed to go into the market except after the FDA approval in university. And they do not give the permission for the drug to be used by human except if 2 independently conducted randomized clinical trials are published before they give the approval for this medicine. So therefore, as I told you before, the randomized clinical trial is the best to test the cause and effect and to test the efficacy of any new medication. Then the sample size, أنا شايف إن هم مش هيقدروا يستوعبوا كده السامبل سايز دي، فهم ما بيشوفوش الرغم إن هي أهم حاجة في Are you following me? Are you following me? Is it okay for you? When you conduct a randomized clinical trial, there is very important to calculate for the sample size. For example, if I choose 100 patients, the reviewer of the article will ask you why 100, why not 50, why not 60, why not 200, why not 1,000. So it is not taken haphazardly. We should calculate in any randomized clinical trial, for proper design of this trial, you have to calculate the sample size to obtain a successful randomized clinical trial that could be published in a high impact, in a journal of high impact trial. How to calculate the sample size? This depends upon the power of the study and the expected difference between the study and the control group. Don't be afraid, I explain this in a very simple way. So what is the power of the study? To understand the term power of the study, you have to understand two important items. What we call type 1 statistical error and the type 2 statistical error. What is type 1 statistical error? You will not understand it except if I give an example. So I'll give example first. You know that the term significant, you know the term significant, what does it mean? When I say that there is a significant difference. You know? You know? Okay. This means that the probability of error is less than 0.05. If the p-value or the probability of error is less than 0.05, this means that the test is significant. Okay? So look at this example. If I design a study, for example, that I want to make correlation between gender and renal cell carcinoma, then I did this. I compared 100 males and 100 females for duration of 10 years for the possibility of occurrence of renal cell carcinoma. And then at the end, I found that females has a statistically higher incidence of renal cell carcinoma as the p-value was less than 0.05. This is the result of the test. But in reality, this is not true. If the sample size is 1,000 males and 1,000 females, the result will not be statistically significant. See, so here you have a small sample size, but you obtain the statistical significance. But if in the reality, in the population, you increase this 100 to 1,000 males and 1,000 females, you will not obtain the statistical significance. So, type 1 statistical error is defined the probability of demonstrating a statistically significant difference in selected sample when no true difference exists between treatment and larger population. Well, you have in research, you have sample and you have population. You cannot do the test over the population or the whole population. So you choose a sample. And this sample should reflect the result if you repeat the test over the population. Okay? If you choose a sample and you did your study and this sample resulted in the statistical significance, so the p-value between the groups is significant, that is p-value is less than 0.05, so the sample is positive, but the population is negative. So this is type 1 statistical error. Okay? So everyone in the world can accept the type 1 statistical error in the range of 5%. So if it is in the range of 5%, it is acceptable. Therefore, there is no 100% sure of anything except God. Everything could be changed except God. Okay? So in medicine, in statistics, everything is changeable. But you do probability. So again, if in a sample you obtain the statistical significance, but this is not true in the population, so this means type 1 statistical error, and we can accept it in the range of 5%. Okay? What is type 2 statistical error? I'll give you another example. if your objective is to study the effect of neoadjuvant chemotherapy on survival of patients with bladder cancer, you need neoadjuvant means that you give medicine before doing operation. Give chemotherapy, then you do operation. Patients for bladder cancer, before doing cystectomy, you give chemotherapy. Then you do cystectomy. So this is called a neoadjuvant. يعني ما قبل العملية, before the operation. So you design the study like that. You choose 100 patients with bladder cancer. You give them neoadjuvant chemotherapy followed by cystectomy. This is group 1. And 100, the group 2, 100 patients, you did cystectomy alone without neoadjuvant chemotherapy. And then you do follow-up for 5 years, and you obtain no statistical significant difference because the p-value is more than 0.05. This is type 2 statistical error because if the sample size is 1,000 in group 1 and 1,000 in group 2, the difference will be statistically significant. انت نمت خالص الراجل ده ناقص خالص. انت مش معايا خالص ولا ايه؟ طب معلش اقعد تاني يعني مش عارف اعمل ايه عشان تصحى. I'll explain again. Here the sample, we have sample and we have population. Here we are studying the efficacy of treatment of patients with bladder cancer. So the population is all patients with bladder cancer. Okay? And the sample is 1,000 patients, 100 patients taking the type of therapy, and another 100 patients taking another type of therapy. So this is the sample. The sample of 100 here and 100 there, the result gives no difference. But in the population, in all patients with bladder cancer, if you increase this sample size, it will be significant. So this is type 2 statistical error. So I defined it like this. The probability of failing to demonstrate a statistically significant difference in the selected sample when a true difference actually exists in larger population. And this, most investigators accept type 2 statistical error in the range of 20%. Again, we have sample and we have population. If the sample, in the sample, there is significance, but this is not true in the population, this is type 1 statistical error. On the other hand, if in the sample you failed to obtain a statistical significant difference, but in the reality, in truth, in the population, this is real, this is true, this is significant. So this is type 2 statistical error.
If I'm doing, according to my understanding, if I'm doing a new trial of treatment, or I'm doing experimental trial, I'm expecting, if I'm having a sample size, the treatment I'm doing and should be effective as the same as the sample size as in the larger population.
Good.
But an error can happen whether type 1 or type 2. Type 1 in sample size is affected by the treatment, while in larger population it's not affected.
Yes.
And vice versa is type 2.
Yes.
So these are two types that should not happen in my experiment, but they happen, and I'm not expecting them.
Yes.
And that abnormal.
Yes. Therefore, we guard against this, but in limits. We have to accept the errors, because as I said, there is nothing perfect except God. But there is a margin of error. Nothing is perfect. We accept a margin of 5% for type 1 and 20% for type 2. Okay? So to avoid this,
She doesn't understand what's meant by 5% error or 20% error. This is a mistake. Understand.
One
هتيجي دلوقتي طيب يعني انت كده مظبوط، انت مش فاهم كده كويس. To guard against this, we calculate for the sample. This is an introduction. I'm just doing introduction on how to select the sample size. Okay? So, a type 2 statistical error means 80% power. The sum between of type 2 statistical error and the power of the study should be 100. If type 1, the type 2 statistical error is 10%, it gives you a power of 90%. If 20%, power of 80%. If 70%, it gives you power of, if 30% error, gives you power of 70%. So most people cannot reach 100% power, or 90% or 95%, it is difficult. So they can accept 80%, around 80%. Okay? So 80% power implies 80% probability of being able to demonstrate a statistically significant difference between the samples if the true difference exists in the larger population. Okay? If I say that this power is 80%, the power is 80%, so means the sample, within this sample, if I apply it to the population, it gives you accuracy of 80%. Okay? خلاص? So this is the power of the study. The second item is the difference between the study and the control. What does it mean? There is, as I told you, randomized clinical trials are not started from the scratch. It should be followed by some other types of studies. So from other types of studies, you read other types of studies, and you see the difference between the study and the control groups, according to the previous publications. And according to the difference between the study and the control groups that had been published before, and putting into consideration type 1 and type 2 statistical error, you can calculate the sample size. For example, the difference here, as I told you, you look to the previous similar articles, and the expected difference is the expected outcome in the study group minus expected outcome in the control group. Again, I'll give you an example. A study drug A versus drug B. Drug A is the gold standard, and the drug B is the gold standard is the control. Okay? And the drug B is the study. And the previous studies showed that the difference in the results is in the range of 25%. This means that the sample size should be 50 patients in each arm. If the difference is 20%, you need a sample size of 100 in each arm. If the difference is 10%, you need 250. If the difference is 5%, you need 500. If the difference is so small like 1%, you need 3,500. So the larger the expected difference between the study and the control arms, the smaller the sample size, and vice versa. The smaller the expected difference between the study and the control arms, the larger the sample size. Okay? This is estimated just, numbers are just approximation, not accurate. And these numbers are set considering type 1 statistical error of 5% and type 2 20%, giving a power of 80%. If you want to to have more accuracy or more powerful study, you have to increase the sample size. And this table is present in all books of the statistics. Here, the results, the outcome in the control, 2%, 10%, etc. And here is the outcome in the study, 1, 5, 10, 20. And here is the time to statistical error. And for example, this 10% gives you 90% power. So if you want to have, for example, 90% power, then you see the effect in the control 2%, and here the effect in the outcome, for example, if it is in the literature 1%, so the difference between both of them is 1%, and this will give you a sample size of 3,696, etc. So from this table, you can accurately determine the sample size in each arm according to your wish of the statistical, of the power of your study. But this is not important. I want you to understand just the idea. The idea. You are not going to do this. Just have a broad idea how to select a sample and randomize it clinical trial. What is type 1 statistical error? What is type 2 statistical error? What is the power of the study, etc. Okay? And this is a practical example how to apply a sample size in a randomized clinical trial. A randomized controlled trial studying the effect of alpha blocker on the increase of spontaneous passage of distal urethral stones. You know that alpha blockers could be used to facilitate passage of stones from the lower end of the urine. So we want to test this, the effect of alpha blocker on the spontaneous passage of stones from the pelvic part of the urine. Previous articles showed that the study group gave a success rate of 90%, and the placebo group gave a success rate of 65%. This is according to previous articles. So the difference between the study and the control group is 25%. So if I want to have a power of 80% statistical power, so the sample size should be 50 patients in each group. Is it clear? واضح ولا ايه؟ مش واضح. طب مش واضح ازاي يعني؟ نعم؟ احنا قلنا بالجدول اللي فات.
The idea is not to go with the study. The idea is to do study which has been initial and will change our mind. So we want to know exactly how many patients in the study will be expressed. Okay? So from this study, from the previous studies, it's partially 90% in the active group comes to missing, and in the placebo 65. So the difference between active and placebo is 25%. To run a randomized study to give us a good idea about this drug, we should have at least 50% activation. So to do a good study, we should have at least this number of patients in each arm, at least. So as the difference is here. If the difference is 5% as translucent example, we should have 50 patients in each arm, so 100 patients under randomization. But if the difference from the previous studies is 1%, we should have 3,000 patients to run into the study. So,
ايوه انا بقول لك ده ريفرنس بس ده ابروكسيميشن.
to determine the
انا لما بقعد اقول لك 51 و52 انا بقول 50 يعني في الحته دي يعني، لكن انت لو عايزه تجيبيه بقى من الجدول مظبوط هناك
هو ريفرنس المفروض ما اعرفش هو جت ازاي، بس
جت ازاي مش انت اللي هتجيبيه، الاحصاء هيجيبه وهيجيبه من الجدول اللي انا قلت لك عليه.
احنا بس
يعني let's start with expensive. السبب بتاع الجلسة
لا ازاي؟ ما احنا عمالين نتكلم ادينا نص ساعه، ما هو بناء على ايه؟ ما هو ده بناء على ايه؟ ما هو ده بناء على ايه يا ابني؟ بنقول الكلام ده يعني ما هو ده بناء على اللي انا قلته قبل كده. يعني احنا قلنا عشان تحسب لازم تعرف يعني ايه تايب 1 statistical error وتايب 2 statistical error عشان تحسب الباور اوف ذا ستادي. وعشان تحسب الباور اوف ذا ستادي معمول الجداول بتاعتها، فتقدر تشوف الديفرنس ما بين الستادي والكنترول جروب according to previous studies، وعلى اساسها تقدر تحدد السامبل سايز. كل دول ما استخدمناش الايرور ازاي؟ كل ده assuming ان التايب 1 within ال 5% والتايب 2 within الجدول ده.
لازم يبقى 5%
لا هنا الجدول ده كله assuming تايب 1 في 5%، وفي هنا الفروقات بتاعت تايب 2. وهنا الاوتكم في الكنترول، وهنا الاوتكم في الاستادي. فكل استادي ليها الظروف بتاعتها. انا بختار دراج ايه ودراج بي. في البريفيوس ستاديز كان مثلا الاوتكم بتاع دراج ايه كان 2%، والاوتكم بتاع دراج بي كان 1%، وانا عايز باور 90%، يبقى السامبل سايز ماشي كده. انا دلوقتي في الاوتكم في الكنترول جروب كان 2%، وفي الاستادي جروب كان 5%، وانا عايز باور اوف 80%، يبقى هو السامبل سايز ماشي كده. مشينا احنا بقى 2 10 20، ممكن يطلع بقى في السكه دي في النص ده يعني ايه، مش يعني الموضوع تقريبي، لكن الكمبيوتر هيجيبها بالظبط. التمثيلوسن ده الميديسن الاكتف ميديكيشن الستادي. بتقولي ايه؟ لا بس بتقولي بس ما انا بستفيد من السؤال بتاعك.
I want to evaluate absolution against the procedure. So I reviewed the literature regarding the preface of the last study, and I found that on my study stated that the difference is 25% as per Shokeir. So I apply here to calculate my sample size to be expressive.
ماشي احنا خدنا
we consulted as a statistician.
لا الكمبيوتر السوفت وير بتحط فيه الكلام ده كله. تايب 1 statistical error 5%، تايب 2 20%، السامبل سايز كذا، الديفرنس اللي انت عايزه كذا، هيروح خطوه واحده يجيبها لك على طول. بس انا بقول لك ازاي بيجيبها.
So sample size is calculated by BI, principal investigator, or by statistician.
Look, you have to be responsible for every word in your paper. اللي بيسقط الناس في التربيه ايه؟ اكتر حاجه بتسقط الناس في التربيه انه يعمل مقاله تيجي تقول له انت السامبل سايز دي حسبتها ازاي؟ هي اجابه واحده، يقول لك انا ماليش دعوه، انا ما بعرفش في البحث، ده الراجل بتاع البحث هو اللي قال لي كده. يسقط على طول. السؤال ده ما حدش ولا واحد بيترقى بيعرف يجاوبه. ايه رايك بقى؟ ماشي كده؟ عشان كده انا كنت اتمنى بس حد من اعضاء التدريس يكون موجود، لان ده السؤال اللي بيسقط الناس كلها. كل ما واحد يجي يترقى، يا ابني انت جبت البتاع دي ليه ما كان 50 ليه مش 60؟ ما فيش كوميونيكيشن ما بين الستاتستيشن والكلينيشن ساعات ما بيبقاش مظبوط. therefore you cannot understand the statistics from the statistician. You can understand it from the clinician. The statistician can explain to themselves because they speak at a very high level. But among the clinical community, you should hear statistics from a clinician because thinking on the same wavelength.
If I want to work on the first time, and when I put the picture there was no preference on the last one, what was it?
But this could not be applicable because there should be, because if this, as I told, this is a phase 3 trial,
Yes.
it should be followed by phase 2. Phase 2 should be, there should be phase 2. There should be some previous studies on some limited, now they take some clue about the results. اصلا انت ازاي هتعمل فيس 3 ستادي من غير فيس 2؟ ففيس 2 هو اساسا لما عملت فيس 2 هو ده اللي allows you to make some كده بالبركه كده تروح تسمي ده وتديها 100 عيار ده اللي هنا وتشوف هيأثر ايه. واخد بالك وبعدين الناس هتقيس عليك بعد كده تشتغل عليك بعد كده.
You said in type 1 you have investigator with set 5% and type 2 50%. So how we want to get this percentage with this table?
This table, all the figures are put into consideration of 5% statistical error type 1. Because type 1 could be less than 0.01, less than 0.001, etc. But to make it easy, most of the clinicians accept less than 0.05 as an acceptable way to accept type 1 statistical error. خلاص؟ يعني I want to skip this يعني because هم مش هيعملوا randomized clinical trials. يعني this is advancing on practical example that from scratch. خلاص this was يعني not for the students. This is for possible after that. Okay. شكرا.
Because I cancelled the third one. So it's just 1 hour or 1 hour, some minutes, okay? And it's very important, very important. Why is this presentation very important? Because it discusses one of the most important issues in research, which is consent for research. Today I'm not going to discuss what's meant by consent and the theoretical backgrounds behind consent, because I leave this issue for Professor for another presentation. But today I am concerned with the practical issues. So I give you the presentation, and during the presentation I invite some of you to apply what I said. Okay? So to start with, it is training for the OSCE session. So you will find in the OSCE exam, in the research station, the consent for research. So if you understand me today, and if you apply what I'm saying, you will harvest the full mark. The outline, I start with introduction for the communication skills. How to communicate with the people. Because it's very important for the doctor to be good communicator. Don't understand this statement. A good doctor is a good communicator. And I add to this, a good actor as well. So sometimes you feel discomfort from your daily living complicated problems, but when you face the patient, you should be professional. You should be professional and good actor. Okay? So I speak a little bit about the some slides for communication skills, and then I demonstrate the principles, and I give 2 examples, and then I end with this declaration. Okay? So start with communication skills. What are the communication skills you may know? By other words, how can we communicate with others? How can we communicate? What is your communication? What are your communication skills? Verbal skills. As I am speaking today, I speak suppose that I am speaking and you are speaking too. Is it a communication, good communication? Bad communication. So communication, even if it's verbal, I should one speaking and one listening. If we speak together or we listen together, there's no communication. So these are the principles. So the communication skills, it is not only speaking and listening. There's verbal language and there's body language. And I'll demonstrate these issues in the next class. So a good communication is essential to the presence of high quality medicine. Even in research or in the practical medicine, I should be good communicator. Okay? So we have not only verbal, as you see here, there is verbal, thinking, listening, and non-verbal. My question to you, what are the non-verbal communication skills? What are the non-verbal? Yes, facial expression. If I'm speaking with you and I'm smiling like this, or I'm speaking and looking at this, so it's non-verbal. Okay? What else? What's body language? What else? So suppose that I'm speaking to you and all the presentation I put my head like this. And I'm speaking. Communication skills are very important. Is it a good way? No. If I'm speaking to you all the presentation and this, there are 4 communication skills. Think, listen, remember. It is bad. So I know it is not in the process of consent. Now, in the consent we use all the communication skills that we can use. So we have verbal, non-verbal, and even if I'm listening to you, if you speak and I'm listening, if you are a patient and speak to me and I listen to you attentively, this would be good for you. This will reflect that I am interested in your issues. If I take a consent and I'm speaking to the person who I want to invite him to participate in the research, and he is asking a question, I'm listening, you would consider this is as I am interested in the issue and I am respecting this person. But if he asks me a question, I invite him to participate in my research. And he knows, well, that this is for research. So the great benefit is for the research community. And then I don't care with this patient. I said to him, yeah, this is a researcher to come here to participate. Then he asked me a question, I'm not concentrating with the patient. How does he will be convinced by these issues? He will not be convinced by participation in research. So to do an effective consent process, I should know what are the communication skills to be used. And they are 4, as you see. Speaking, I speak to the patient in a reasonable way, in an interesting way, reactive way. All these are good speaking. And when he asks me, I should listen. So listening is very important as like speaking. Sometimes I should think, but if he asks me a question, and then I look at him in a steering wheel like this, and then goes for half an hour, it's not thinking. This is bad issues. I should think spontaneous, okay? And non-verbal using body language. And the body language, as you see, facial expression. And facial expression usually will keep a professional smile. We should avoid the looking aggressive to the patient. Gestures, posture. So if the patient, it's better to run the interview while I am sitting here, for example, and the patient is sitting here, or the person for whom I want to have a consent is sitting beside me. And so I'm sitting the same level of his face. I'm looking to him. Suppose that he is speaking like this and I'm looking. I want to say, and then this is bad issues. I should respect the person I'm speaking with. Body movement should be rational. Smile and touch. We should avoid touching the person. because touching is violence. Except if it is done momentarily, like it's okay, but shouldn't be wrong. Okay? And the use of voice and sound, volume, pitch and tone, and professional use of silence. So if I continue speaking very loud, is it accepted? If I'm speaking, there are 4 communication skills to be used, and I continue like this, it's okay? It's bad. And if I'm speaking, there are 4 communication skills, and I'm speaking like this, it's bad. So I should use I shouldn't be monotonous. Look at this face, please. Look at the facial expression of this lady. What is the best facial expression you may see? Which is the best photo? If you are a person who is invited to participate in research, and you see the person who take the consent, which is the best and professional face that you like? Why you select the first one from the first row from the left side? Why? It's professional smile, not opening. If you look at the second one, this opening the mouth more than enough. Why she is opening the mouth like this? And why she behaves like this? It's not a good way to communicate to the person by this facial appearance. And this is side view, and this is mentally retarded person. So I should be appropriate. I should be appropriate in using the facial expression. Look at this facial expression. Which is the best? Second left. From where? If you look at the facial expression of this man, no one is professional. Nothing is professional. Either he is very anxious or has facial palsy, or so all this are bad. So we shouldn't use his appearance. If I ask you, this is Shokeir, one of the pioneers in the field of one of the best actors. Shokeir. If I say to you, this is an appearance of compassion and the merciful love. Am I right or wrong? Can you describe this facial expression? Can you describe the facial expression here? Can we use this? Yes. Can we use this with our patients? When we ask them, what's your complaint? Then we look at his face by this facial, it's bad. It is cannot be used. What about this? It is very nice and the kind of way of discussion with the patient. So it's very boring. If the patient is confronted by a doctor like this, it's very boring. I noticed one of doctors in nephrology behaving like this. So the patient was followed in the clinic and the creatinine increased progressively to the extent that the patient's condition states starting hemodialysis. So what the doctor did is he informed the nurse to give the follow-up card of the patient saying to him, go for dialysis. And the patient comes to meet the doctor. Why dialysis? What's fistula? Because the nurse said to him, go for creating fistula for a surgeon to perform a fistula for you and start dialysis. And then the patient wants to listen from the doctor. What's meant by fistula and what's meant by dialysis? And then the doctor was very angry, was very anxious. This is a fistula and he did like this. So the patient doesn't continue the thing and go away and run away. So this is not a good communication. Don't forget to be empathic, to show clinical empathy, because empathy is a clinical procedure, and the doctor is the drug. What's meant by empathy? Nice empathy, to be nice with the patient, to show him some compassion. الأرض يعني تبقى عطوف معاه وتتكلم معاه بطريقة كويسة وتتفاعل معاه to react positively with the patient. This was meant by empathy. And don't forget that you are the drug. So you can find a patient saying, when I go to the clinic and I found this doctor, I feel comfortable. And this is one of the best doctors. And when I go and I found this doctor, it's very bad. And I feel that I am embarrassed from the presence of this doctor in the clinic. So we should be nice. Okay? Don't forget that to be a good doctor, you have to be a good communicator. Don't forget this issue. What's meant by informed consent? I read the details of the theoretical background behind consent for Dr. Harun, Professor Harun. But today, I am concerned with the practical issue. So informed consent assures that prospective research subjects will understand the nature of the research and can knowledgeably and voluntarily decide whether or not to participate. So this one of the most important word here is voluntarily accept to participate in research. So no man is good enough to govern another man without the other's consent. So before the persons or the patients participated in research, they should first consent voluntarily to participate in research. This is one of the most important issues that is usually not inappropriate in our locality. So the structure of the consent, when I invite a person to participate in research, I start the interview with introduction. So it is first to say, welcome, hello, good morning. My name is Hussein. I am a researcher in this research. Do you know the research idea? Because in the Western community, they send the research project and consent form to the patient before the interview. So when the patient comes, they already read the consent form. But here, they usually don't read anything. So I first acknowledge him for coming, and then saying to him, I am a researcher, and this is I start to introduce the topic of research for him. This is a new research to prove the efficacy of new drug in treating. This research is devoted to prove the new diagnostic test. Whatever the reason of research, I should introduce the topic for the patient. But I should be sure that the patient understands everything. So I can repeat and then ask him if he understands or not. Because it's not a matter to allow him to sign, because signature of the consent is not contract. The patient has the power to withdraw himself from research at any time. Okay? Understand? You understand me? So I start with welcoming the patient and then explain to him in a very understandable manner what's meant by this research, what's the research idea. So this is the introduction. And then the research purpose in a simple manner. And then qualification to participate. I say to them, to participate in this research, we have inclusion and exclusion criteria. So you should be subjected to evaluation, and this evaluation includes history, examination, and probably some investigation to be sure that you are within the inclusion criteria of this research. So this is qualification, was meant by qualification to participate. And then design and duration. This is a study, 14 weeks. We'll start today, and this is the procedures that we will move through the follow-up period. And the risks and discomfort. We should explain to the patient risks being participating in research. So this is a research, and you will receive this drug. The side effects of this drug is so and so and so. You will be subjected to maneuver, and the maneuver complications are so and so and so. So you should explain to the patient everything, because informed consent means consent after explaining to the patient everything, to know the consequences of this consent. Rights of withdrawal. I should emphasize that you are free to withdraw from the study at any time in the study frame. It is very important. And then the benefits of participation in research, and new findings may appear, and we should put at the time the alternative plan of management, and we should assure the confidentiality and the privacy, and the policy regarding research-related injury. Usually, there is no long-term policy regarding research-related injury. There is a short-term plan of management, and then the long-term, there is no assurance for the long-term consequences. And the compensations, contacts, I should, at the end of the dialogue, I should leave the contacts telephone. And if I take blood samples or tissue samples and then I apply some new tests on this tissue or blood sample, I should declare to the patient everything in a clear manner. And the patient should sign, and sometimes they invite witness like nurse or third party to sign that he witnessed this consent interview. Okay.
So this is a consent, not a random experiment on human being and a patient.
Excuse me?
And this is a consent taking from the patient and taking permission that there are new trials of drug or anything عليهم.
I should take consent, yes.
ويبقى
كل خطأ. All these steps are within the consent procedure. Okay? So it should start with introduction and end with signature.
هو أنا أصلا ينفع consent على human being قصدي ينفع
But all research that will not be done on a human being, and if I use any human subject, I should have the consent of this patient that is voluntarily agreeing to participate in this research. But if I collect the perspective, if I look at the data in the hospital, then I don't take consent from any person because I don't do harm. There is no possibility of any harm for a person. I just collect some data from the archive of the hospital. So there is no consent. But I should take the consent of the research board in the hospital about any research project. But when I should take a consent from a human being involved in a study, that I do study on a person. So I should have this consent. But if I collect the data from the hospital, there is no consent from patients. You understand me now? Okay. So the consent should be one of the research items. We should have a consent from any patients participating in research. So to approximate these issues, I should apply to the example. So this is the patient. The patient is invited to participate in a research project to evaluate a new diagnostic test for early detection of chronic kidney disease. So I am a nephrologist and I start with this example. But I can apply for liver disease, cardiology, any specialty. So here, we invented a new diagnostic test applied to urine analysis. So the new test is urine analysis. And the gold standard is renal biopsy. So I wanted to prove in this research if I can examine the urine, and this will replace the renal biopsy later. So to reach this conclusion, I should prove first in this research that applying this new test can replace renal biopsy. So I should do urine analysis and renal biopsy for the research, and then at the end I can conclude or not conclude if the urine testing can replace renal biopsy. So I invite all the patients, and all of them will be subject to to urine analysis and renal biopsy. And at the end of the test, the end of the study, I'd say that I applied the new test of 1,000 patients, for example, or 100 patients, or whatever the number of patients included in the study, and all of them were subjected to biopsy. And the test was concomitant with the result of biopsy. So I can apply this test in the future instead of the biopsy. So this is the rationale of the study. The rationale of the study is to prove the efficacy of new diagnostic tests applied in urine examination to replace the invasive procedure of renal biopsy. So here, how to take the consent from the person to participate in this research? Do you imagine if I ask a person to give me urine for examination, is it difficult or easy? It's easy. But the difficulty in this scenario is to convince the patient to do biopsy for him, to be subject to renal biopsy. Okay? So this is the previous batch of students, and you can see here they act well with me. So the important question in the ask session, you'll find a newspaper in front of the room saying that you are one of the research center team, and your job here is to convince or not to convince, to take the consent from the patient to participate in research. And the research idea is to prove the new diagnostic test in urine to replace renal biopsy. So it is the role player will ask you this question. The role player do the job of instead of the patient, real patient. So what is my benefit if I agree to participate in this research project? So if you meet a person and then you welcome him and then you say to him, I have an idea for a new test that will be applied, and if it is proved in this research to be beneficial, we can replace urine examination by renal biopsy by this urine examination. Okay? Then the patient asks you, what is my benefit if I agree to participate in this research project? What will be your answer? If this is a first question, what is the proper answer?
Explain the aim of the research. Explain the aim of the research.
What is my benefit? This is the question.
So maybe this research will help in curing him.
What is my benefit from participation in this research? No, for me. So this is a biopsy. You will take part from my kidney. What is my benefit? This is a research, who knows well that we want to invite him to participate in research. If you say to him, okay, there is no benefit, they will say thank you, goodbye. I think the proper answer for this question is, okay, this is a new test that depends on urine examination, and if we prove in this research project that testing urine can replace renal biopsy, this will be a great favor to all human beings to diagnose early chronic kidney disease by examining urine. And you may really have no bad benefit. But you first you said to him, you may benefit all the human beings. So I start answering this. This is a test for a new diagnostic test in the urine, and if we succeed in this research project to prove the efficacy of this new diagnostic test, and you can replace in the future doing renal biopsies, will be a great favor for all human beings. So you will benefit all the community, and you may not directly get the benefit.
But if the patient is not uninitiated?
Excuse me?
The patient is not
you will find the rest of questions that the patient will ask you what's meant by biopsy. What are the harm of doing biopsy?
Yes, I know, but when we explain that this is for the benefit of human being, I don't think they will understand since this is not his.
You know, you will continue speaking with them. You know, this is the idea of research that we don't know the answer. So to know the answer, we should do the research, and this research should be done on a human being to reach this answer. And your participation in this research will benefit all the community. If they at the end say, I'm not educated, I'm not convinced by this issue, goodbye. He has the right to refuse or accept. He has the right to sign for you at the end or say no. See you later. I make my mind, I will come back to you. Or I refuse this research. I'm not convinced. Sorry, doctor, I'm not convinced. Okay, thank you for your time. There is no salary for the patient to consume the research. No salary. يعني مش الأرض مش هقول تعالى هديك 100 جنيه وعشان خاطري مش الكلام ده. No, there is no, because this is not good for research. Because if I do so, you know that a lot of people have no money, and you will find that this is a bad. It's not good for human beings to have these issues. But the patient or the individual should participate voluntarily in research. Okay? But sometimes I may give him a meal, I may offer him a car, okay, to bring him and this may be. But to give him money to participate in research is not a good issue. Okay? So what is my benefit? You will be actually benefiting all the community, and you may not directly get the benefit. But if we succeed to prove that the new test applied in the examination can replace kidney biopsy, this will be a great favor to all humankind. This is the answer. What is meant by renal biopsy? What is meant by renal biopsy? If this is the question, what is your answer? What's your answer? This is not the definition. This is a procedure. What's meant by renal biopsy is to take piece of your kidney. How to take it is another question. So, renal biopsy, this is a scientific terminology, means to take part or a small piece of your kidney. Okay? Will be there out of pain? Is it painful? Is it painful? Is it painful? So it will be done under anesthesia. So you will feel some discomfort just while we are introducing the needle of anesthesia. And after that, you will feel no pain. So just the pain of needle. And he is accustomed to have injection, so they know what's meant by needle. Okay? So it is little pain while we are introducing the needle, and we will inject the material that alleviates the pain more after that. So there will be no pain during the procedure, but the pain is only while we are applying the needle of local anesthesia. How the biopsy will be done? How it is done? How the biopsy is done? This is a question. How biopsy is done? So the biopsy, you should know. So why I'm asking you the question, I know that you don't know how the biopsy is taken. But the answer is, the biopsy is currently done with the guidance of ultrasound machine. So the biopsy is done under the guidance of machine known as ultrasound. By this machine we can see the needle while it is introduced in your kidney. So first, we localize the kidney by the ultrasound, and then after injecting the local anesthesia, after this infection, injecting local anesthesia, we introduce the needle of the biopsy toward the kidney, and we see the needle, and then we take the biopsy under the ultrasound guide. Okay? So it is taken under local anesthesia with ultrasound guidance. So this is how the biopsy is taken. The next question, what are the complications? What are complications of biopsy? If you say to them, be sure we are 100% perfect, there is no complication, and because you are concerned, the problem is you are dealing with a human being, and you should put in your mind, he has the right, or she has the right to say yes or no. So you just introduce the topic to them in a professional way. What are the complications? The complications, you can say the complications are minimal, that's accepted. But if you say there is no complication, this is not professional. The complications are minimal. The most encountered complications is really some bleeding. So you find your urine red after the biopsy. Sometimes it may be more than that, and you feel some retention. But be assured that this occurs so infrequent, and if it occurs, we can deal with all these issues in a professional way. Okay? The next question is, am I going to die? Am I going to die? What is the answer? What's the answer? Am I going to die, doctor? You have the God, Allah will, that you know if I am dying or not?
No, you will not die.
You wanna die?
All of us will die. This is the only fact. No, you shouldn't. Don't say to him, all of us will die. This is a fact. It's a joke for you. This is a good answer. Be assured, I am one of this research center. The experience of this research center is approximately 30 years, and doing biopsy every day, and no reported case of death in our center. Although it is reported very, very rare in some centers. So I start with my experience. No deaths in our experience, but in remote possibilities exceedingly rare. For each 9,000 biopsies, you can find in the report one or two patient died. So one in each 9,000 patients. But in our center, I am working in this center since a couple of years. But the experience of this center is 30 years. Renal biopsy is done on a daily practice. There is no reported case of death in our center. But exceedingly rare, it was reported from elsewhere that the patient may die. But it's very, very, very rare. Okay? So I answer him in a correct manner, and I give him the truth. Okay? I don't deceive him. But if the patient asks you, am I going to die, doctor? And then say, no, you will not be convinced by you. This is not professional. Okay? And when I asked role players, because role players, the exam are students from Manchester, and the student that worked as a role player asked the other student, am I going to die? It is not a good way to say, to ask him a question, am I going to die, and then smiling. You should be anxious, angry, afraid of death, afraid of participation in this session to die. So you should say, am I going to die, doctor? In a serious manner. What are the precautions to lessen the occurrence of complication? Okay, doctor, I know now the biopsy is done by ultrasound and there is a possibility of some bleeding. So what are the precautions that you will do to lessen the occurrence of this complication? The precautions are the
Pre-biopsy, yes.
Pre-biopsy preparation will post-operative care or post-biopsy care for the procedure itself.
Excellent, excellent. So be assured that we'll do our best before, during, and after the procedure. What are the precautions, doctor, that you will do before the procedure? Before the procedure, we will measure your blood pressure. If your blood pressure is high, we will not do biopsy, except after controlled blood pressure, so blood pressure should be normal. We will order complete blood count to see if the platelets are normal. We will test your ability to bleed, or your tendency to bleed. So we will test you by bleeding time, a test known as INR or prothrombin. And if all these tests are normal, we can proceed for biopsy. Okay? During the maneuver, we'll be strict, professional, sticking to some standard of care in doing the procedure, and after, and we'll do it with minimal she's sleeping. Okay. With minimal invasion, so it is done one attempt. We don't exceed 3 attempts. If we fail to take proper tissues after the 3rd attempt, we'll stop. Okay? And after doing the procedure, you will be observed in the department for 8 hours. Okay? We will measure your blood pressure and ask you if there is any blood in the urine, and we will treat everything in a proper way. So these are the precautions. Precaution before, during, and after. Okay? The next question. Am I going to stay long in the hospital? How long the patient stays after the biopsy? It is 8 hours under observation, and usually we will discharge the patient next day. So only 24 hours stay in the hospital. And some centers do it on an outpatient basis, but we don't like that. We should observe the patient for at least 8 hours. The patient stays still in the bed, doesn't move, to avoid any bleeding. And after that, he can move freely, no problem. In the second day after the biopsy, so after 24 hours, we can discharge the patient from the hospital so long as there is no problems. Okay, any question in this session? Okay. After is there any restriction to my activities after doing biopsy? Avoid what? Avoid I don't know.
And you should take precautions with the food after.
No. Avoid straining and carrying heavy objects for 2 weeks. Because the needle is introduced through the skin, muscle, kidney. So this is, and when the biopsy is taken, the biopsy includes arteries from the kidney. So this is a wound. If the patient carries heavy object, immediately after the procedure, there will be a possibility of bleeding or complication. So we advise the patient for regularly doesn't strain or carry heavy objects for 2 weeks after biopsy. Look at this marking sheet. So this is 20 marks. This is distribution of the marks. If you introduce yourself, if you come, you will come and find the examiner, like me, or another examiner, and the role player. When you enter the room, you should first open the interview. You will find 3 marks for opening the interview. Okay. So 3 marks for opening the interview. 12 marks for the obtaining the and here awareness of time limitation and expressing interest marks, 12 marks for all these issues, and 3 marks for closing. If you answer all the queries, all the questions, then you should ask him, do you have any other questions? No, doctor. So would you please consent to participate? Okay, doctor, and this side, thank you for coming. Bye-bye. This is the end of the interview. But if you finish the question, then stop. You will lose the 3 marks of the closing interview. Okay? Understand? So this is a classic OSCE session for the research sector. I want 2 from here and 2 from here to play this consent process. Okay? I want 2 students from this side. 2 students. One will work as role player and the other will take the consent. So come here in the field. These are the questions in the back. So, okay. So we'll start now the experiment number 1 from the female students. The examiner will not ask you anything except when you enter, okay, where is your ID, and write your name, your ID, and then just walking at the interview. No questions, and at the end you give the mark. So you can start the process now. There will be a paper beside the room saying that you are a student, that you are a list of lab or whatever, and you are one of the research center, and your job is to take a consent for this test. And the safety question is you are one of the research team involved in the research to prove the efficacy of new diagnostic test in urine examination and to detect early kidney disease in comparison to gold standard renal biopsy. And your role is to take the consent of the patient to participate in this research. Okay, go ahead. 6 minutes. The interview is 6 minutes. Urine analysis to compare the result taken from this application of new test for urine examination. And to be sure that this test is good, we should compare it to the results of renal biopsy. So the patient will be subjected to both urine examination and renal biopsy. And your role is to take his consent to participate in this research. Okay, go ahead.
My name is Dr. Rowan. I'm from the Urology Center. Can I speak to you about our new research? Okay. First of all, what are we doing? So, Malak,
So this is
we're supposed to be doing the name of the patient.
this is a good start. She reacts in a nice way. And then ask her about the name, you'll find the name in the sheet. And it is very, very crucial and important to use the patient name. Because if you say to me, no, it's better to say Dr. Hussein. It's better to say Malak. Okay? It's better to, because the most sweetest issue for the person is his name. So if you call the person with his name, this is a very good issue. So keep this in your mind.
So Malak, here in the research and the urology center, we are doing new research. It's on the efficiency of the relation between the urine of the patient and how we should correlate it to the biopsy.
So first, Malak, to improve the new test in urine that can detect the changes of the kidney or kidney disease. And to be sure that we achieved our goal, we should compare the results of urine examination to the gold standard, which is examining the tissues from the your kidney. Okay? So do you know what's meant by biopsy? The renal biopsy is to take a piece of your kidney.
Oh my God. And what is my benefit from this?
Okay, this is, as I said to you, this is a new research. We don't know still the result of this research project, but we prove in this research that خلي بالك أنا أكون بتكلم when I'm speaking I look at her eyes because KBI contact is one of the non-verbal language. Because of I say this is a new test and I'm looking at not the other people, this is not a professional. So if we prove in this test that the examining urine can replace taking biopsies to be accurate for human being, really human will get the direct benefit. Now to explain this research and we prove the test to be useful to be good for human being. You may not give the direct benefit. Benefit may be for all humanity. That we can replace our rats in doing biopsy by examining urine by applying the new test.
I'm asking about the medicine.
Okay. No, sorry. You will feel a little pain while using the needle of anesthesia, and after that you will feel any pain.
And how the biopsy is needed?
Yes, it is a needle introduced to the kidney by the complete guidance of a machine as ultrasound. So I see the needle while it's introduced toward the kidney. Usually the complications are minimum in our practice. Just some patients may have some blood coming through the urine and it's just days and disappear. But sometimes it may be more frequent, that may lead to some retention of urine. But it occurs usually after the procedure and we deal with these issues by our means.
So I'm not going to blood?
She asked me, am I good at it? I should say yes, you're not.
And am I going to blood?
You are asking the professionals. Get the floor. Am I going to lie? Answer is, I joined the research center since 5 years, and there is common experience from this center for 30 years, doing biopsy as a daily practice, and there was no reported case of this in this center. But some centers, it's well, exceedingly rare reports of this, so from 9,000 to 5,000. But we don't have mortality answer.
And what are the precautions that you are going to take to eliminate complications?
I want you to be assured that all of the we will do a lot of precautions before, during, and after doing the biopsy. So before the biopsy, you will measure the blood pressure. If we find your blood pressure is fine, we'll not do biopsy. So your blood pressure should be within normal. And we'll apply some laboratory investigation to be sure that you are not susceptible or have a tendency toward bleeding. So it's as a sort of complete blood count to know the count of the platelets, and some tests like bleeding time and time in the heart. And if all these tests are normal, we can proceed for biopsy. And during the maneuver, we'll be very careful. We don't exceed 3 attempts of doing to take the biopsy. And after the biopsy, we will be served in the department, measuring the blood pressure for 4 hours, and then then you stay for another 4 hours in the bed without moving, and after 6 hours you can move freely in the department. And that's it.
And how long I have to stay in the hospital?
You stay for 1 day only, so if you are okay, next day you will be discharged from the hospital.
Is there any restrictions I should do after doing this medicine?
What I want to stress about that, this is a law, so you are not allowed to carry heavy object or to strain for 2 weeks.
Thank you, doctor.
Do you accept to participate in my research?
Child.
Would you please sign for me? Thank you.
Why? Because if you do this test in the exam, you will have 20 marks. 21 over 20 marks. The same. Excuse me? No. Just MSQ, MQ, and Muslim.
Assalamu alaikum. Hi, Ahmed. It's me, Dr. Duran from the Urology Center. Can I speak to you a little about our research? Okay. I'm Ahmed from the research team, the Urology Center, and we are doing a research about the unit biopsy. We take part of and we see the relation between it and between the color of the urine.
No, it's not an object of research. The objective of research is
We have a new diagnostic test. New diagnostic test in urine, in examining urine, okay, to detect the early kidney disease. But to be sure that this test works, we will test it against the standard of renal biopsy. Okay, so the rationale of research is to prove a new non-invasive diagnostic test in urine. It's not to do biopsy and to compare with the color of urine. No. We apply a test, diagnostic test in urine examination, and we want to be sure that this test works. So we should compare against the global standard, which is renal biopsy, for early detection of kidney disease. So please, before you enter the room, you should read the paper on the wall carefully to know the aim of this, and you should use the same words, the aim of the study. Because we may go to the another scenario.
Okay, renal biopsy is that typically complicated. So, you want me to tell you about the procedure?
very nice use of non-verbal language. She is looking to the eye, and I work in a professional way. So, deliberation.
I will ask what is my benefit. What's the benefit?
Well, the benefit is that in helping in finding this diagnostic test, it will make him a huge good favor for the human being. Maybe not a direct benefit, but it will help in curing and a lot of human being activity. The procedure is simple. We take a needle and first of all we detect the site of the kidney we want to take part piece off, and this is by ultrasound, and then under anesthesia we insert the needle and guided by ultrasound, and we take this piece off. The whole procedure is done under anesthesia, maybe only as a part of entering the needle you feel some little discomfort, but overall you will not feel pain. On the accurate method and the accurate procedure and technique, the complications is very minimal, but you maybe find after a week or something red urine, but this is very normal. This is somehow expected.
Commonly, we find some bleeding in the form of just coloration of urine in a manner, and it disappears within days. But sometimes it may be more severe than that lead to some retention of urine, but we will deal with this by introducing catheter and manage properly.
Am I going to die? Well, I have worked in the center. I'm saying well yet.
Dear doctor, it was this session. Am I going to die?
I worked in this center for 30 years, and among these 30 years, we never found any case of death. But even in the very, very rare cases, it has been certain that 1 out of 9,000 may be a case of death. But inshallah, with appropriate technique, you will survive from this. And what are the precautions you are going to take? Well, this is a wound, so it's very important that you should not strain or carry any heavy objects after the. This is very strict. And what are the precautions you are going to take? We have previous to the procedure, we give you we do some investigations to assure the bleeding. We do platelet count. And we measure the prothrombin volume. And even during the procedure, we do it on an accurate steps and in a very professional way. And after the procedure, we have you in the hospital for 24 hours for monitoring and making sure that everything is okay.
Is there any restrictions or Shokeir?
It's a wound, so you shouldn't strain or carry heavy objects after the procedure for 3 weeks.
Thanks.
So are you approving to participate in our research?
Yes.
So maybe you can sign here. So anything you want to ask about before we do the So thank you.
You should be careful like that. Okay? Non-Egyptian, 2 students, male students, 2 champions from the nation. What's your name? See. Who will be the patient? So you just know this. See, for sure. Listen to example. It's not a confidential concept. When you are discussing
Hello, how are you? My name is Dr. Hussein, and I'm from Urology Center from MANSOURA Department. So, but before we start, may I know what's your name?
My name is Shokeir.
Okay. How are you? So do you, before that I want to ask you to take your consent about we are going to do the speed test. Doing that test to test the kidney function. So using urine analysis, we want to compare with the gold standard one, which is renal biopsy. So, do you know anything about the test?
I have no idea how it is.
Don't smile.
So we will take a sample from your kidney as a part of your tissue from your kidney, and then It will be done under general anesthesia. Sorry, it will be local under anesthesia. So
the biopsy is not under local anesthesia. Once the patient is in wrong position, and then after this infection to that, we put the probe in the renal angle. The renal angle lies between the last rib and sacrospinal muscle. If we put the probe in this place, we can see the kidney on the ultrasound machine. So it's regularly done under local anesthesia. Sometimes we do general anesthesia for children, for small kids, because they move or grow and we cannot do biopsy while they are moving. So in rare situation, we do light general anesthesia in children.
This is the same scenario. Okay, that you're finding an example.
What is the actual main purpose of this? Main purpose of this study is what is the main research? How do we see?
For this study, we want to diagnose kidney disease. Why? Just examine urine to detect the chronic kidney disease by a new diagnostic test in urine examination. To be sure that we are okay, we should refer to the gold standard of kidney disease, which is biopsy. Because the gold standard for diagnosing kidney disease is to take sample from the kidney and examine this sample under microscope to be sure that there is abnormality in the kidney structure. So when I want to invent a new non-invasive test like examine urine, I should refer to the gold standard test, which is biopsy. Okay?
do you have a question for that?
Will there be anything?
The pain is very minimal, but the procedure will be done under anesthesia, so you will feel a little discomfort from the puncture of the needle, so will be maybe minimal pain.
How the biopsy will be done then?
So first we will yes. First biopsy is done under ultrasound. So then first we localize the site of the renal. Then after that we disinfection and then put some the local anesthesia. And we will introduce a needle, okay, and use the guide of sound, okay. And I think that's all.
Will there be any complications?
From my experience, it's very rare. Maybe one or two in okay. So the complication may be some bleeding and urinary retention, but we will follow up in 8 hours after the procedure. So you'll be here after the procedure is done.
I know this might sound mad, but are there any death occurrences that may occur to you?
You don't have to worry because from my experience, it's very rare occurrence of death after during the procedure. It's about 1 or 2 in 10,000 cases. So you don't have to worry about it.
At your point, how would you like to decrease the complications?
Okay, so I will explain the main idea of this procedure, we will do, we take first take your blood sample, test your blood pressure. So if not suitable, we will not proceed with the biopsy. And we test your also bleeding time, INR, and so on. And during the maneuver also, we will make sure that all will be professional doctors will be involved, and just minimal invasion. And the procedure will not exceed more than 3 attempts, okay? And we will follow up after the procedure, and we will keep it here 8 hours and not more than 24 hours.
Will there be any restriction to my normal activity after that?
No. Just you will rest at home after that. So, are you agreed to be involved to participate in this research?
I think
It's not appropriate to say to her, you will stay home after that. If my daughter wants to stay home, no, you should say to her, just you should avoid carrying no objects or training because there is a long just for 2 weeks. So you can move freely, but avoid carrying objects for just weeks until the whole begins. Okay? Last question.
could you give me some time? Because I don't want, I think I don't want to people.
Okay. No, it's okay. Okay, thank you. Bye-bye.
So this is very important. This is a very important to know how to take a consent. I think there is no time for the example 2, because example 2 is this patient is invited to participate in a randomized control trial to prove the efficacy and safety of new drug for treating bronchial asthma. So this is a patient with bronchial asthma, and I want to convince him to participate in a research that introducing a new drug for treating bronchial asthma against standard treatment. So this is another issue with consent. I think we may leave it for another occasion because of time. Okay? So we'll leave the randomized study consent for another time. But I want to finish with this declaration. This is a World Clinical Association declaration of Helsinki. As you see, all these are issues, different issues in evolution, and the last one was in 2008, and currently on the net you'll find this draft since April 15th until June 15th for the public to just to vote and to improve, and then after that it will be final. And this is the draft. Look at the draft. I think if you write in the Google the World Medical Association Declaration of Helsinki draft, you'll find this issue. And you'll find it is concentrating on ethical principles for medical research involving human subjects. Because human research using human subjects is very, very, very crucial and very essential to respect the human being if I'm treating a patient. And if I deal with the tissues as well, it is very, very important to follow the steps. If you read this declaration, you'll find 37 items discussing all issues regarding the research. So you can find all these issues if you refer to this declaration. For example, here is the informed consent, participation by competent individuals. It's very important because I can't take a consent from mentally retarded person. So this is a vulnerable group, and I think Professor Haruni will give you an idea about vulnerable group and how to approach them. There is no time for that today. So, under the sector of informed consent, participation by competent individuals as subjects in medical research must be voluntary. And this is the key of the research. We shouldn't oblige any person to participate in research. If we do that, this is bad for humanity, and this is unethical and prohibited. So, patient should participate voluntarily. Although it may be appropriate to consult family members or community leaders, no competent individual may be enrolled in a research study unless he or she freely agrees. So consent is one of the ethical goods of doing research. In medical research involving competent human subjects, each potential subject must be adequately informed of the aims. So these are the constituents of consent. Aims, what is the aim of research? Methods, source of funding, any possible conflict of interest, institution of researcher, and etc. When seeking informed consent for participation in research, some physician should be particularly cautious if the potential subject is in independent relationship with physician. So you can read all these 37 points because all of them are ethical points regarding the control of the research project when we use a human subject. And will be in effect from the coming June, because this is the new version. So I end with two quotations: love and compassion. Compassion بالعربي أنا استخدمتها كتير معناها حنان ومودة. So love and compassion are necessities, not luxuries. Without them, humanity cannot survive. So we should deal with the patients in a love and compassion. And lastly, all I wanted was to reach out and touch another human being, not just with my hands. And I want this issue to be put in our heart and our mind, to touch the patient by our heart. Okay? كده يبقى خلاص النهارده finish today. So the next appointment is next Monday inshallah.